Unbelievable, Joe. My slides are here. I think Joe only invited me back this year because those that were here last year would have seen Joe challenge me by being able to present without slides. So, well, Joe, I'm not sure what's going to be in my slides, right? So we'll wait and see what surprises you have for me. But interesting to see the amount, Andreas, the data, right? That we have, and the IMS and Brogan data that's out there. And I guess, Michael, if we don't like the IMS Brogan data that's here today, stay tuned, you'll change it in a quarter anyways, won't you?
To be clear, there's never enough.
Yeah, there's never enough. It's either +3 or -4 to 6, right? It depends on which CEO they're talking to and what data they need to be able to share with their global head offices. So let's just go through. I want to talk about the challenge of reimbursement. So I'm not going to go through a whole bunch of data slides with regards to how bad reimbursement is, because I think you guys know that. There's not many drugs that go through CDR, and the ones that go through CDR don't get approved very quickly at the formularies. So I'm going to talk a little bit about a couple influencers that are happening right now that I think we need to pay more attention to. And first of all, health technology assessment. We thought we were the ones with CODA, that is, that an old name for some of those that have been around, we're influencing. But now health technology assessment across the world drives our decision making locally. And you may not see that, but you're looking at the decisions made by NICE in the UK, the decisions that are made in Germany by their health technology assessment, what's happening in Australia, is impacting us here now. And we have to look out and beyond what's happening from a Canadian perspective. As well, from a local perspective, the demand for risk sharing and deals, price concessions to be able to reduce growth. And there's not a formulary I go to right now across the country that someone says, okay, well, that's the list price. It's almost like going and talking about selling a car now. That's the MRSP. What's the actual price? What are you going to put on the table for it? And that's being driven by the global downturn. It's not going to stop, right? And at the same time, we're faced within our own companies on launch sequencing. And I'm not sure if anybody's had those conversations on what price you can get and how you sequence your launches across the world. I wanted to take a step back and kind of look at kind of the evolution of the reimbursement environment. What's happened? And I look at back in the 70s and 80s, we went out and aggressively promoted to physicians. We got our NOC and we went out and we promoted our indications. And some people would say, yeah, those were the good old days, right? Those are the good old days. You got your indication, you went out and you talked about your features and benefits. Then we kind of moved into the 80s, and by show of hands, how many people know the name John Downton? So we have a few folks that have been around for a bit, right? And then came in we needed to provide some clinical data for support. And I tell an old story about going to see John in Newfoundland, who was a drug plan manager back in Newfoundland. And the data at that point in time is John needed to see the product monograph, needed to see the price, right? And you'd go down to see Gene, who was his admin, and you'd get reimbursement. That was the 80s, right? The 90s kind of came in and we now needed to provide clinical and economic justification, leading to what we now know for those that work in the field a lot is EJP, economic justifiable price, which looks at what your clinical data will allow you to price and how does that compete with the products that are out there. To get into where we currently are right now, which is everything's a negotiation. You need to be able to have good clinical data. You need to have the right price, and then you need to be able to talk about what you can do. And I know there's lots of debates on whether you sit on the fact of whether you do or don't negotiate, but that's the world that we live in. That's the unfortunate component about it. Innovation is just one piece of the puzzle. You need to bring that innovation. That's now the cost of getting into the discussion. And then the next steps is, where are we going to go? So there's also some true game changers that are coming and that are going to influence what's going to happen as we move forward in the future. DSNE, the Drug Safety Effectiveness Network. Bob Peterson runs this group. Bob Peterson also used to be the head of TPD. Bob Peterson's also the head of CDAC. Some of the decisions that are being driven out of CDR are also being driven out of the Drug Safety Effectiveness Network, and these will impact how we're going to go into our next level of negotiations over the next decade and what we're going to bring to CDR and how we're going to move forward. Patient and disease groups and individual patients. Just recently, we would have seen how an oncology patient has, in an election time frame, has truly changed how you can get some reimbursement. You're seeing lots of it occur at patient groups and individual patients when products aren't getting reimbursed, how the pressure, specifically in different timing when we're in election cycles, can change decisions made at governments. Pharmacists and their prescribing roles. You also have seen in the most recent Ontario budget where there's money being put in to the pharmacy budgets to be able to not necessarily prescribe, but provide advice and counsel. And their evolving role will change on how things get prescribed and how things will be reimbursed. And physicians, unfortunately, you go back, physicians have lost their role. They are the primary giver of health care, but they're being driven right now by what's on formulary and the guidelines. And the guidelines and reimbursement are driving it. I'm not sure how many people have been to a physician lately and they take out their little pad and they look at what's on the formulary, and can they get it covered? Does the patient have public or private coverage, and can they move forward? I talked about the increasing role of health technology and the reliance on it. This will continue to escalate. There'll be more and more reliance on health technology. Escalating negotiations. I won't go into this too detailed, but that payers will be looking for new models to negotiate pay-per-performance, conditional listings, life cycle considerations as you bring in your drugs with regards to you have one indication and the next indication's coming along, how will you manage that? And we need to get into the discussions on how we strive to strike a balance, and we need to have discussions well in advance, 18, 24, 36 months in advance of you bringing a product to market. You need to be talking to the payers. So in conclusion, market access excellence or reimbursement excellence, only the companies that are adaptable will succeed in this. You need to make sure that this is part of your day-to-day thinking. No longer a marketer can worry about, Andreas and I were having a quick conversation, worry about what color the detail aid is. They need to understand pricing, they need to understand market access. It needs to be part of thinking as the product's coming through development. It needs to be as part of getting into discussions with the payers early. Pharma companies are forced in changing how they look at their go-to-market strategies and how much investment they're going to put into market access. All pharma companies, should push their employees as they're coming through, especially early in their development. Make sure you get training on this area because it will be a discussion at pharmacy, with patient groups, and with physicians. And remember, it is a journey. It used to be a destination reimbursement, but reimbursement has turned definitely into a journey. Thank you, and I think I'll turn it over to Kevin.